Welcome to the AUA Inside Tract Podcast. Today's Inside Tract Podcast is part of the Meet the Subspecialties series and is brought to you by the Residents and Fellows Committee. Dr. Woody Smelser, Assistant Professor of Surgery in the Division of Urology at Washington University in St. Louis and past Society of Urologic Oncology Fellow at Vanderbilt University, sits down with Dr. Bogdana Schmidt, Urologic Oncologist at the University of Utah in Salt Lake City, to explore the subspecialty of urologic oncology.
All right, well, welcome. My name is Woody Smelser. I'm recently finished fellowship at Vanderbilt and beginning position as a urologic oncologist at Washington University in St. Louis, and it's my pleasure to be joined by Dr. Bogdana Schmidt. Dr. Schmidt, would you like to tell us a little bit about yourself and your background?
Absolutely. Hi, thank you so much for tuning in, and hopefully this will be a fun experience for everybody. Learn a little bit about us, about urologic oncology. So I'm Bogdana Schmidt, as Woody said. I started as faculty at the University of Utah just this fall, so less than a year out in practice, which has been amazing. I trained mostly on the West Coast. I did undergrad and grad school at UCLA, medical school and residency at UCSF, and I did my urologic oncology fellowship at Stanford. Woody and I met a couple of years ago at the Society of Academic Urologists back when we were both just starting our journey applying into urologic oncology. So this will be a fun time to recap about our journeys and kind of how we got here.
Yeah, and just sort of by way of introduction, I did most of my training in Middle America. I grew up originally in Missouri on a family farm and did my college and med school at the University of Missouri in Columbia. I crossed the borderline rivalry and did my residency at the University of Kansas, and then fellowship at Vanderbilt. And, as Dr. Schmidt alluded, she and I have known each other for a couple of years through involvement in academic and organized urology. And part of the reason I'm here today is I've served the last 6 years on the Residents and Fellows Committee. And we as a group have wanted to work to give sort of more information from early career perspectives about careers in various subspecialties. So Dr. Schmidt and I will guide you over the next half hour or so through some considerations for a career in urologic oncology. So Dr. Schmidt, for maybe medical students or early residents who are just starting to get their feet wet, tell me kind of in your own thoughts, what the scope of practice and the organ systems, the disease spaces, techniques, et cetera, that you sort of encounter in a typical urologic oncology practice.
Yeah, the elevator speech is it's everything that urine touches and then a couple extras. So with urologic oncology, we deal with the kidneys, cancer of the kidneys, the cortex of the kidneys, the renal cell carcinomas, and the lining of the kidney, your urothelial carcinomas, bladder cancer, prostate cancer, penile cancer for our male patients, and testis cancer as well. And the breadth of urologic oncology is kind of the most exciting part about it is obviously big organ systems, but also the different approaches to these cancers. You have your minimally invasive laparoscopic robotic surgeries. You have your big maximally invasive open surgeries. You have endoscopic surgeries. There's really nothing that you don't get to do in urologic oncology, which I think is what makes it really interesting. And of course, you get to build incredible relationships with patients at a time when they truly need someone to be their guide and their friend. And I think that's the most rewarding part of our jobs.
Yeah, I endorse and agree with every bit of that. And I think, just a couple things from a historical perspective for trainees to think about is, 15 to 20 years ago, everything you just described was done in an open fashion. And in some cases, as we joke, in a maximally invasive fashion.
Yeah.
And over time, that has really shifted to where the lion's share of a lot of cases can be done in a minimally invasive fashion, but there still is the need for, big wax or larger cases that require, significant exposure. And then I think another really interesting thing, not only in the operating room, but also just in the holistic care of the patient, is that we do engage in a lot of multidisciplinary care. And on any given week, we may work with surgical oncology, vascular surgery, on high level, vena cava thrombectomies and things like that. We may even get into the chest and work with a cardiothoracic surgeon. We work in the pelvis with colorectal surgeons and with gynecologic oncologists. So we really have to be team players, I think, to be effective in the 21st century. And then in the clinical setting, we work with medical oncologists, radiation oncologists, pathologists, radiologists, So one of the things that I like about urologists is, to paraphrase what you said, it's not just everything that urine touches and some more, but it's also almost every specialty in the hospital that we get to interact with and work in a professional manner. And for me, that's one of the more rewarding aspects of this job.
Absolutely agree. And to add to that, actually, one of the things I've noticed I'm doing more of, which is a field and a specialty I haven't interacted with as much before, is the role that genetics is starting to play in our field, and the relationships we're building with genetic counselors, and how they can come with us and with our patients and bring a lot of information and practice changing advice to their care, same as engaging with our palliative care colleagues as well. So yeah, you're right. There's no one we don't work with.
Yeah. And, on the genetics note, sort of the subtext there for the sort of newer listener is that there are so many urologic cancers that have underlying either monoallelic sort of genetic disorder, or even a familial inherited, sometimes even, dominant mutation. And there are cancers now that we can screen for and identify as a result of cascade testing of family members of those who are affected, and intervene and potentially add lots of years of life on the back end through sort of thoughtful screening. And that honestly is an aspect of this career that just over the last 7 years of my training since finishing medical school has really evolved. And I want to kind of seize on something else you said, which is, about the integration of palliative care. So I actually had a background in hospice as a volunteer in college and continued in medical school. And I agree. I think palliative care is an area where we as urologic oncologists have to be field leaders and sort of leading those conversations. We often quarterback and coordinate a lot of the care with other subspecialists, and palliative care is no different. And I'm trying to be very deliberate early in my practice about building clinical scripts where I'm, meeting patients for the first time and counseling them about high-risk cancers, about consideration of palliative care someday, which, may be decades down the road. And in some unfortunate cases, maybe much sooner. And so I'm really glad you emphasized that part as well. So we've kind of gotten into some of the elements of my next question. But, tell me a little bit about, why would somebody choose a field like urologic oncology?
It's the best. That's easy. But really, I think it comes down to, especially early on in your training, you have to listen to yourself and what you're drawn to. And I think one of the ways that I was sort of taught to think about it is figuring out what appeals to you more: inpatient versus outpatient, higher acuity versus lower acuity, continuity of care versus enhancement in somebody's life in that moment. And that's the role you play in them. And for me, urologic oncology really was the combination of all of those things. I like building relationships with people, whether that's colleagues or patients. I think that those longitudinal relationships make a really big difference in our overall just satisfaction with our lives. At least for me, I feel that way. I think the surgeries are great. I think for an oncologic specialty, urologic oncology outcomes are really a lot better than a lot of other oncologic processes. And I think that's
Absolutely
encouraging. And it's great to be a part of someone's life in that way. I also think just the way that our field has taken off over the last 5 to 7 to 10 years, and the dramatic improvements in our patients' care and lives that we've been able to offer them, whether it's with our medical oncology colleagues and some of the newer advanced therapies versus some of our new enhanced recovery pathways and robotic surgeries, and having our patients tolerate our surgeries better than they used to. All of that was really exciting to me. So I guess in a nutshell, it would be the research aspects of the field, the technical surgical aspects of the field, and the longitudinal relationships I get to build with patients. That was the most important part.
Well, you stole all the best parts of my answer, but I'll let it slide. And
I'm sure you can find a couple more.
Yeah. You know me, I'm not short on words, but I will say, for me, it was all those elements you said. And then I had some actually just peripheral life experiences, even as a young man. My dad is a farmer. One of his best friends had very high stage testis cancer, kind of in the mid 90s, was treated by an all-star team at Indiana that included Dr. Einhorn, who is one of kind of the pioneers of chemotherapy for testis cancer, and Richard Foster, who was part of the crew that sort of helped perfect open RPLMD. And seeing him go through that, even, when I was pretty young, 10 or 11 years old, and then later an uncle who had bladder cancer, I was sort of oriented to exactly what you said, that even with high stage disease, urologic oncologists can impart treatment plans that really have great outcomes, as opposed to some cancers where even after, half a century of discovery and development, the 5-year overall survivals are still pretty dismal. And then kind of when I got to medical school, a lot of it was the mentors that I adopted. And then, one thing obviously that you and I share is we also both have what I like to call nosocomely acquired spouses. My wife's a med-peds hospitalist, and I found that our work is different in exactly going back to what you said, and that she's very efficient and has, and this is not to diminish what she does, but I do really think that if I did what she did, where she went into the hospital for 7 days, took great care of patients, and then left and maybe never saw those patients again, I would find that would sort of leave a gap for me. And so those longitudinal patient relationships that you're talking about, I think, are what really keep me in this interested and passionate about this field. So,
well, we're the kind of people who can't be efficient that way, right? When you're off, you're still checking up on your patients, and you're still trying to say, you can't let go. I understand that.
Yeah, I'll try not to do it during this 30-minute podcast, but you're exactly correct. So, but maybe I'm asking a question that's prime, but can you talk a little bit about how, being a 2-physician household sort of has influenced your practice, influences your decision-making, that sort of thing? Because I don't think it's as unique as we think. I think, around 1 in 5 physicians are with another healthcare professional. And so I think it does have a bearing on specialty selection.
Well, my husband's a dermatologist, and certainly that makes it a lot easier than him being someone who also has a high inpatient care burden. So his schedule is more flexible, which is wonderful for us. But I think that it, to me, has been amazing because my husband understands. He just understands when I have bad days. He understands when I'm stressed before a case or after a case. He understands if I'm distracted, then it's not because I'm not, focused on him or the family right now. It's because there's someone else who has entrusted their care to me, and I'm thinking about them too. Yeah. So I think that's the most helpful part, and I'm very grateful to him for that. We have 2 kids, and our kids have heard way too many doctoring conversations already to the point that their questions are getting a little more pointed now, which it's kind of fun as well. But for those who are still approaching this or thinking, is urologic oncology family friendly? I would say that everything can be very hard and everything can be managed. And it's all about how you approach it, how you try to structure your life. I figured out that trying to achieve some state of balance is absolutely impossible for me. And I focus on truly just trying to be present. So it's presence in the day, in that moment. If I'm with my kids or I'm with my husband, I'm 100% committed and devoted. And if I'm with my patients, that's where my energy is. And some days it'll be 50-50 and some days it'll be 100-100. Yeah. But when you have a spouse who understands, it works out.
Yeah. And I think that's one of the things that's drawn me to urologic oncology, like you said, is that it can be managed. And in full disclosure, I have 2 children as well. And one thing we share is that they were born during various phases of training, and that can be a challenge, but it's not one that can't be worked around. Nope. And that may play a role in sort of the next topic we're going to talk about, which is the training pathway, types of fellowships, locations, picking the right program. If you are a person in whom family is a consideration, there's a lot of programs. I think that's helpful, and we'll get into some specifics about that and about the match. But just in general, could you kind of outline what the typical training pathway looks like, and sort of just an overview of the basic types of fellowships, and then we can talk about the match?
Yeah, absolutely. So obviously, a path towards urologic oncology will start with a urology residency. And usually, depending if you're in a 5-year or 6-year program, kind of halfway through your program, you're going to start thinking about it, trying to develop an area of interest and define some mentors and support. Because if you choose to apply for urologic oncology fellowship, you will have to fill out an application that'll require some letters, probably some research interests in the field, though I would say doesn't necessarily have to be within urologic oncology. I think the research has to define your interest and ability to form good questions and do studies, and doesn't necessarily have to be in oncology, but for many it is. And you apply to that fellowship program. If it's an SUO program, that'll be a 2-year urologic oncology fellowship that will involve a clinical year and a research year. And some programs have their research year first, and some programs have the research year second. And that can also factor into your decision-making, picking programs. There are good reasons to do it either way, and we can talk about some of the benefits of each.
But I think that sort of underscores an important consideration on all this, which is the role of mentorship. And sort of as I alluded, one of the reasons professionally why I've gotten into urologic oncology is I had some great mentors, and that started as a medical student. I scrubbed into cystectomy and neobladder as a third year, and the chief resident was there, and he kind of sarcastically said, "Well, I hope you ate lunch because you're going to hate this. You're not going to be able to see." And 5 hours later we were done, and I was like, "That was the coolest thing I've ever seen, and that's what I'm going to do with my life." And so, I think finding a mentor, someone you look up to, or who can look after you if you need attending a little bit, is really important. And it's okay, I think, if you're at a program that maybe doesn't have a strong urologic oncology presence, because I think people in the SUO tend to be willing mentors, and you see even on Twitter or other social media that young trainees engage sort of seasoned oncologists, and usually it's a great discussion and offer for mentorship, et cetera. And so, tell me a little bit about the mentors you've had.
Oh, I've been the most lucky person ever. I trained at UCSF, and my program director when I was a trainee was Dr. Kirsten Green, who's now chair at University of Virginia. And I remember just looking at her, who, she wore 4-inch heels to clinic and would do however many surgeries anyone could do and lose 2 cc's of blood every time and just make it all look easy. She's a true inspiration. But I think mentors, like you said, they can be people you work with in your own institution, but you don't have to limit yourself that way. People who have gone through fellowships. I remember very much seeing former oncology fellows throughout my training when I was from being a medical student to a junior resident to a senior resident. Other oncology fellows whom I've seen go through UCSF have become friends and mentors to me as well. And I've developed networks and relationships thanks to them and to conferences and social media now that have been really grateful. And also putting a plug for myself and for Woody, we're always happy and excited to chat with people who are interested in urologic oncology. I'm happy to offer us as mentors to people who would like to reach out.
Yeah. And for those listening to this, and you don't have a mentor or you want a perspective kind of about the landscape of current fellowships, Dr. Schmidt and I obviously are both happy to add that, and they can put our email in the show notes as well.
Yeah, I think that would be easier than spelling out my name right now.
Yeah. So, and just sort of along those lines, we would be remiss if we didn't talk about the actual mechanism of the match. And so, the typical timeline, and this varies slightly from year to year, is that, as Dr. Schmidt had said, you will apply in either your 4th or 5th year of training, depending upon if you're in a 5 or 6 year program, respectively. And you will complete a final year of training before you actually matriculate to your fellowship. And that is different than some other specialties. And what that sort of requires is that you do have to think kind of mid-residency about what path you're going to pursue to sort of start your fellowship campaign. Normally, applications begin to open at the end of November, which is around the time of the winter SUO meeting. I cannot underscore the value of potentially attending the Society of Urologic Oncology winter meeting to meet with program directors, meet with fellowship directors, meet with current fellows, former fellows. I think it's a really crucial network to tap into.
I completely agree. I think attending AUA and SUO over the years, AUA I always find a little bit more overwhelming, and The SUO is the meeting where I've had more of a chance to really meet people and interact with them and build those relationships. So I completely agree. The SUO meeting is a great one. Early on, don't be intimidated if you're a medical student or a junior resident. People are really nice. They want you to succeed. They want to be a friend. They want to help you.
And I think the other interesting thing about the SUO meeting is that when you attend it, you have that opportunity to start to sort of fill out programs before you actually go on site for interviews, or in the case of the last couple of years, most of the interviews have been virtual. But I think that that's useful. And usually applications are due kind of the end of January, but typically they're reviewed on a rolling basis. So the people that I've advised over the last year or two, I've recommended that they try to have their application materials submitted within a couple of weeks of the end of the SUO meeting, which is always in the 1st of December. That way, when they meet with people at SUO and say, hey, you'll see my application soon, and you can put a face to the name. And then interviews usually are kind of in March, April, or maybe early May. Certainly very few of them occur after that spring AUA meeting. And then the match is usually in June. So it's a little bit of a prolonged timeline. Honestly, it takes about 6 months from start to finish. But it's a great opportunity to interview programs because unlike the match, which is a little bit like the Hunger Games, where you're just sort of vying to have a seat when the music stops, you will have some options as a fellow applicant, and the match rate's typically quite good. And the AUA Residence and Fellows Committees have implemented some policy changes over the last couple of years, including allowing the few, but sometimes present unmatched applicants access to the list of open program slots. So we're trying to do things in a thoughtful way to get all those spots filled with quality candidates. But nonetheless, it is a contractual match, and so once you match, you're sort of obligated to fill that spot if you're going to pursue SUO fellowship. There are, as you've alluded, some non-accredited fellowships in oncology, and those can actually serve people, I think, quite well, depending on what they want their practice focus to be. They just don't come with an SUO certificate. So
and most of those don't come with a protected year of research either. So they tend to be popular, and they are popular for the reason of increasing your experience with some urologic oncology cases, whether that's robotic cases or bigger open cases, depending on which program you pick. Certainly an extra year can make people feel more comfortable if they're entering a community-based practice with a focus on oncology, or a more remote rural setting where they feel like they'll be the bigger game in town. I think they can be a great way to enhance your skill set, or maybe get you into a location that you're more interested in. But I think they're different than the SUO fellowship, primarily just based on the research aspect and the more kind of traditional academic route that people take with the SUO fellowship more often. Though plenty of people with an SUO fellowship are doing great work in the community, and I think it's great.
Yeah, and the SUO does have a mechanism for people who do not attend accredited fellowships to become members, and don't pin me down on the exact number, but basically you have to show through case logs, et cetera, that for a number of years you had at least a 75% focus on urologic oncology in your practice. So there is still a route.
The grandfathering in.
Yeah. And they acknowledge obviously that people's situations change. So, and that kind of leads to another important thing, which is what all of us are going to be when we grow up, which is, a surprisingly difficult vision sometimes to formulate. So talk to me a little bit about how one can go about formulating their early career sort of research or career plan based upon their fellowship and the things that are offered.
Well, I think we touched on this already. A lot of the time it really is mentor driven, and finding people whom you click with and people who are interesting to you and who you want to be, whose career you want to have. I think that can be part of it. I also think you have to look at the resources available to you. If you're at a place that has a really big database system, then you can certainly learn a lot from that. It's hard to create or recreate something that's resource intensive in an environment that doesn't have that set up. So I think figuring out what is available to you, what you can learn from that. And sometimes you'll learn that this isn't what I want. And that's why you pick your fellowship that does something totally different and gives you a different perspective is important. I think it's nice that our field is small enough that you can reach out to people at any institution and work with them on something, but also big enough that there are a lot of those people.
Yeah. And I think that kind of hits at another point, which is that there are different types of fellowships in terms of their structure. And, some places, one of the most basic questions I think often we have to decide upon is, do we want to be a fellow at an institution where maybe it's a larger institution or a cancer center and they take 4 to 5 people a year and successfully mentor them and maybe funnel them into a specific research emphasis or even, organ or disease site? Or do you want to be the fellow, which comes with separate sort of trade-offs? And I think you have to kind of have some introspection and think about how you like to accomplish tasks, how you like your life organized, how many people you might want to be mentored by or sort of answer to. And I think that's kind of one important question. I think there are considerations of geography and family and proximity to other things that are important to you. Sometimes SUO fellowships parlay into permanent employment. And so I think you should consider, and this is my bias, but I think you should consider training somewhere that you would not be upset to potentially spend, the first couple of years of your career or maybe all of your career. And there are a lot of great examples of that, of people who have done fellowship in places and become field leaders and never had to pack a suitcase and move. And other times you may say, hey, I know that this is going to be a short stop and I want to use this to get back to the region or market or role that I'm interested in. So that's another consideration. And then I do think one of the values of attending things like the SUO meeting and meeting recent graduates or listening to podcasts like this or looking at other resources is finding out where fellows have gone and what they've done, and picking the ones who sort of represent what you're most interested in, because those institutions tend to have a track record of placing people in similar fashion. So if you're very dead set on, being a grant-funded physician scientist, you should probably look at a fellowship in a place that has a strong, very strong track record of doing those things. And if you're interested in being a prolific clinician, then look at places that have produced those people. But that said, I landed at Vanderbilt, and they've not really had a lot of people who had interest in clinical trials. And I just got recent notification of my first major trial being funded. So I
congratulations.
Thanks. That's not meant to be a humble brag. It's more to illustrate that if you come in with a cogent and I think actionable plan, most fellowships are fertile soil to be successful. And so, I think that I would encourage you to have an open mind in that regard.
I completely agree. And I also, in that vein, want to say that you have to think about the institution as a whole, not necessarily just the urologic oncology division or department, because oftentimes as a fellow, you really have access to people outside of that small group, and they can be very helpful, whether it's the medical oncologists or the genetics or any radiology, imaging, advanced markers. I mean, there's just, the field is so broad, and a lot of institutions have really brilliant people who would be very excited to collaborate with a urologic oncology fellow, even if someone within that particular division isn't doing something you're passionate about.
Yeah, I agree. And the other thing I think sometimes is, certain institutions have funding for obtaining additional degrees that may help springboard your early career or help you learn skills that you didn't have either the time or the resources to learn in medical school or residency. And there are a lot of great examples of that, and really beautiful and I think successful careers and research collaborations that have come out of some of those sorts of efforts. And that does sort of segue into kind of one of the closing topics we were going to discuss, which is, if we each had a crystal ball and had to predict where the field is going, what's your prediction, Dr. Schmidt?
I think that all of healthcare and medicine is becoming more data-driven, which I think is good. I think clinical trials are going to be a bigger part of our lives, which I think is also excellent. I think imaging, molecular markers, genetic testing, all of these things that we sort of learned about in medical school, but I think truly I learned way more about in residency and fellowship, just given the breadth of how much more pervasive they are in our field now. I'm very excited about that. I think if you look at the particulars of any one cancer treatment, most of them have undergone incremental changes in surgical approach, but pretty dramatic changes in overall medical approach. And so I think the pace of the medical treatments changing is going to be faster and greater than potentially the surgical field. So I think urologic oncology is great because we get to participate in both aspects of our patients' care. We get to benefit from the advances in both, and our patients get to have their care improved through that. What do you think?
Yeah, well, I agree. And I think, going back to your assertion about data-driven decision-making, I think that's also going to lead to further personalization because of all the factors that you discussed, advanced molecular imaging and biomarkers, genetic testing, a better knowledge of tumor genomics and what therapies are more effective against what subtypes. And we are seeing examples of that evolve in real time. In prostate cancer, for example, I was relaying to a patient in clinic recently who had metastatic prostate cancer that when I was an intern, there were really only 2 drugs approved in the space that this patient occupies, and now there's more than 10, and the list is growing every day. And so that's exciting. I do agree with you that I think we will have to continue to collaborate with other specialties, or sort of we'll be surgical dinosaurs who are over here in a corner trying to solve problems with only surgical solutions, when really it's going to require a multidisciplinary sort of refined approach. But I do think that, as you said, it is still going to require thoughtful and skilled surgery in many. And so it's exciting that will be retained. And then I think that we'll continue to see increasing differentiation and diversification of our workforce, which is really exciting. And, my daughter already tells me she's going to be a surgeon, so I'm rooting that she's a urologic oncologist. Maybe she can come be your fellow. Maybe she can come be your fellow someday.
I would love her.
but I think that has brought so many new perspectives that have helped us break out of the mold of solving problems in the old way. That is incredibly exciting to me. And then finally, I think we will be forced to have a greater focus on the cost of treatments, because I do think that our patients, because of this explosion of technology and new options for drugs, robotics, minimally invasive surgery, other techniques, is advancing at such a rapid pace. I think that the cost of those treatments are also cumulative, additive, sometimes multiplicative, and we will have to be very thoughtful in our trial design and other things to think about the implications that costs have, because we can formulate the best plan, but if our patients can't afford it and have to choose between, food and medication, or food and gas and medication, that's not a viable treatment plan. So,
no, I agree with you. And also with that in mind, making sure that our treatments are available to people who live in different parts of the country, with different access to some of the best regional centers, with remote care and telehealth, and all of these ways that we're trying to reach our patients now. I truly just hope we keep getting better at that, and that everyone has the access to the kind of doctor that they need.
So, I'm so pleased that you could join me as a guest. And I know I've asked you a lot of questions, but I just want to give you the microphone here, the forum at the end, to ask any additional questions you may have of me.
One question I think would be an interesting one from maybe the medical student or resident perspective is, we've talked about how wonderful urologic oncology is, and clearly we've spent a lot of time thinking that why we want to do this and why it's great. But maybe see if you can lay out some challenges of this field, or some reasons to think twice.
I have many.
And I'll counter them at the end.
Okay. And we don't want to scare anyone off, but I do think, you are dealing with cancer. You're many times when I meet a patient in clinic, they just received literally the worst news of their life. Their support, their family, their spouses, their children may have peripherally or directly received that news as well. So I think the stakes are high, and I think that if you don't have a deeper sort of sense of meaning on why you do this, I think urologic oncologists could be ripe for burnout just because they are high stress encounters, high stakes surgeries. Every scan could be good news or bad news for a patient, and it's very difficult to predict until the moment when you interpret it, whether or not what you're going to be dealing with. So I do think that it is a serious field, despite the positivity that we both tried to kind of exude through this interview. I think that you have devastating complications, sometimes surgically, where you question, everything you've done that's gotten you to that moment, even though you may have performed technically a very, sound surgery, but sometimes things just don't go your way. And I think dealing with that, particularly as an early physician, is challenging. And I think imposter syndrome runs rampant amongst many of us, despite the fact that, I graduated high school more than 15 years ago, and this is mainly all I've thought about since then. And then, kind of the third thing I would say is it is a long training period. There are opportunity costs. Sometimes I joke with my wife that I don't understand compound interest. She clearly does. She finished training 4 years ago and has been in the workforce. So, you do have to think about the impact that has. And I know in medicine, there is, I think, a noble kind of movement towards financial independence and early retirement. And it's not to say that that's not achievable in urologic oncology, but it also, to me, seems like a little bit of a waste of all this time and training for me to want to quit in the next 8 to 10 years, which I have no intention of doing. So, I do think that pragmatically, you have to think about that and think about your personal needs and desires and how that plays in.
I agree. I think all of that is very true. My sort of counter to that is I think everyone in our community in urologic oncology deals with all of those same things that you've mentioned. And I think we really do have a community that is supportive. I know that after tough days in the OR or complications or challenges clinically, I've had people I've called and spoken to who have been incredibly supportive of me and told me about tough days they've had and how they got through them. And I think that for any specialty you choose in medicine, burnout is a real concern, and building that community and that network of people who will support you and help you is really the main way that I've come to deal with it.
I agree. And I think that goes back to one of our central themes, which is about the value of mentorship and people who can support you when those days happen. But I think for me, the bottom line is the good days vastly outweigh the bad ones, and it makes it all worthwhile. So again, I greatly appreciate your time, and I look forward to seeing everything that develops in your career. And thank you for having us for joining us as a guest. So.
Same to you. This has been my pleasure. And like I said earlier, please put my contact info in the show notes, and I'd be happy to chat with anybody offline who has questions about urologic oncology, being a woman in urologic oncology. I didn't touch on that too much, but we are a few but mighty, and I'd love to chat with anyone about that.
This has been an AUA Inside Tract podcast brought to you by the Residents and Fellows Committee. Check out the AUA University podcast for weekly episodes on the latest clinical updates and advances in urology. For more information about the AUA and membership, visit auanet.org.